Hello and good evening, everyone. We are live on the HP Leader YouTube channel at 7 p.m. on this wonderful evening. I'm delighted to be joined by this incredible panel to speak to us tonight about a respiratory and critical care update from the United Kingdom. So I'd first like to start by asking the panel to introduce themselves, and then I'm going to go through a brief of the agenda, give you some stats from here in the UK, and just really why we're here tonight. So I'm just going to go around the screen as I see it. So Pearlene.
Hello, my name's Pearlene. I'm the NIV acute lead at Birmingham Heartlands Hospital, and I serve on the British Thoracic Society's critical care SAG group. And I'm working with them on some guidance on respiratory support units.
Thank you. Zoe.
Hi there, I'm Zoe Van Willigen. I'm the clinical lead physio for critical care at University Hospital Southampton.
Thank you. Charlotte.
Hello, I'm Charlotte. I'm a doctor and researcher at the University of Cambridge.
Kate.
Hi, I'm Kate. I'm a specialist sister from Plymouth. In intensive care.
Thank you. Jonathan.
Yeah, I'm Jonathan Downham. I'm an advanced critical care practitioner at Birmingham Heartlands Hospital.
Thank you. Dorothy.
Hello, I'm Dorothy Wade. I'm a lead health psychologist in critical care at University College London Hospital.
Thank you. Danni.
Hi there, I'm Danni Bear. I'm the principal critical care dietitian at Guy's and St Thomas's NHS Foundation Trust in London.
Thank you. And last but not least, Maria.
Hi, I'm Maria Parsonage. I'm a nurse consultant specialising in respiratory disease and pleural disease. I'm also here representing the Association of Respiratory Nurse Specialists.
Thank you. So we are joined here tonight as, unfortunately, in the United Kingdom, we are suffering yet another wave of COVID-19, and this devastating virus has affected us as healthcare professionals, as family members, as the British public, like anything we could have ever imagined. We are seeing changes in the patients that we're caring for, and for this reason, I'm so delighted to be joined by the panel to share our experiences. Now, we're not going to talk about the only way to do things or what we think is the best way to do things. This is just us sharing our experiences, so there's a disclaimer there, and just really giving you the opportunity to ask questions in the second half of this session tonight. So just to give you some stats from the UK today, from the data today, our daily admission into hospital, I believe this is the last updated figure from the 7th of January, is 4,240 patients into our hospitals. That's on a daily case basis. On the 10th of January, we had a total of 35,075 people in hospital with COVID-19. On the 11th of January, we had 3,363 patients on mechanical ventilation. On the 12th of January, so today, we have had a total of 45,533 people test positive today. We have a weekly death rate of, sadly, 3,417 people. And the total number of deaths so far here in the United Kingdom is 89,243 with COVID-19 on the death certificate, which is absolutely tragic. We have vaccinated 2,431,648 people with the first dose of the COVID-19 vaccine, and over 400,000 people have had the second dose. So that's where we're at the moment. Without further ado, I'm so delighted Dr. Charlotte Summers, who is an absolute world-leading expert in this field. I know she'll probably cringe at me for saying this, and she has been everywhere. She did a session last night for NHS England and ICS, and Charlotte's very kindly going to give us a summary of where we're at in terms of the evidence and therapies. She can only stay the first 15 minutes of the session. She does have to leave. She wishes she could stay, but she's super busy. So Charlotte, over to you.
Brilliant, thank you. I'm just going to share my screen, so give me a moment. I am hoping that you can all see some, oh, screen sharing is, can you see my slides or not?
No, not at the moment.
It's saying that I can't share. Do we need to allow me to? Let's try again.
There we go.
It's worked perfectly. So I thought I'd give you a really high level overview of where we are with treatment and where are we going, because there's been quite a bit of changes in the last few weeks and months. So very easily, what works and what do we know works? Well, steroids. And we know this because the Recovery trial, which is a massive UK-based hospitalised patient study, has shown very clearly that dexamethasone worked. And that's in terms of 28-day all-cause mortality, but it's also been shown in other studies too. And if I whiz through those, there's a meta-analysis, which is the really important thing if you're going to read anything about it, which brought together all of the data on critically ill patients who had COVID from all of the studies across the world. So 7 studies, 1,700 people who were critically ill. So that included people who were having non-invasive respiratory support, as well as those that are ventilated. 678 of them got steroids and 1,000 got usual care. And the primary outcome for the whole meta-analysis was 28-day all-cause mortality, and looking at serious adverse events as a secondary outcome. And as you can see, the overall meta-analysis showed that actually the odds ratio, if you got steroids of death, was 0.7 compared to if you didn't. And it was conserved across what different types of steroids you got, whether you got dexamethasone or hydrocortisone. Methylprednisolone didn't show the same effects, but because the study was really tiny, but there's no reason to suspect that there would be any difference at all. So we think all corticosteroids are probably a good thing for people who are on oxygen or non-invasive respiratory support of any kind, or ventilated. If you're not on oxygen, there is a suggestion from Recovery that there may have been a trend towards harm. So only hospitalised patients on oxygen or higher levels of respiratory support should get steroids. And just for those of you that are interested, actually there was a bit more of a signal towards it having an effect in patients that weren't on vasoactive medications and people who are invasively mechanically ventilated, but there was still benefit in all of those groups. What doesn't work? So again, that's a fairly easy category to talk about. We know hydroxychloroquine, despite whatever Donald Trump may have felt at the time, definitely doesn't work. And we've got good data from 2 enormous studies, so from Recovery and Solidarity, to show it really doesn't work in hospitalised patients as treatment. We've also got data from other studies that show it doesn't work for post-exposure prophylaxis. So healthcare workers that have been exposed to COVID at work, given hydroxychloroquine, still go on to develop SARS-CoV and COVID symptoms. Another antiviral, lopinavir, ritonavir, again from Recovery and Solidarity, didn't work. We had a bit of hope initially about remdesivir from some data in the United States, but actually Solidarity, a much bigger independent study, showed that it was of no benefit. And subcutaneous and intravenous interferon beta-1 alpha has also been shown to not be of benefit. And then there's a whole bunch of things where there's uncertainties, and this is where we kind of get into the controversy and the stuff that's been of interest this week, particularly around anti-IL-6 therapy. So as lots of you will have heard, there was a press release towards the end of November the 19th from the REMAP-CAP study. That's a big platform study across the world, but with most of the patients currently having come from the UK, looking at Tocilizumab. They did usual care versus Tocilizumab, which is an IL-6 receptor antagonist, Saralimab, which is a different brand of IL-6 antagonist, anakinra, which is another type of monoclonal antibody, but to and in the IL-1RA, so interleukin-1 RA, and interferon-1 beta. So they randomized you to one of those 5 domains. They announced on the 19th of November that they felt that Tocilizumab and Saralimab were statistically improving the outcomes of patients for their endpoint, and I'll talk a bit more about that in a minute. So they were shutting the usual care arm of that study. Now, REMAP-CAP's got a slightly different endpoint to the 28-day all-cause mortality for the other studies that I've talked about. They're using a composite of organ-free failure days in ICU, so the days that you do not require cardiovascular or respiratory support whilst in ICU, up to day 21, combined with death. So if you die during those 21 days, you get a number assigned of -1. And for every day that you are free of organ failure free support days, that's quite a mouthful, you get an increase in numbers up to 21. And then finally, on the end of last week, the data came out. And this is very kindly by the MRC Population Health Research Unit. They have meta-analysed all of the available studies about interleukin-6 antagonists based on 28-day mortality among the hospitalised patients to try and make some idea of what happens in the different settings align. And whilst you can see the endpoint for REMAP-CAP here shows that there's a mortality benefit in terms of 28-day mortality in their study, where 108 people received Tocilizumab versus 142 of them had usual care, or sorry, 395 got Tocilizumab and 108 of them had the outcome of interest versus 397 got Tocilizumab. You can see that REMAP-CAP's the kind of one outlier of these studies. And when you meta-analyse them, add them all together, actually there isn't an effect size. It's not significant yet. The confidence intervals cross 1. So we're still a little bit uncertain whether IL-6 antagonism is for all hospitalised patients better in terms of mortality than what we've been doing so far. The recovery trial is currently looking at Tocilizumab. So they're doing it as a secondary randomization. So initially you're recruited into the trial, and then if within 21 days of your first randomization, you still need oxygen because your SATs are less than 92% on air, and you've got persistent inflammation shown by a CRP that's up, you can get randomized to Tocilizumab versus whatever it is the standard of care for you is at that point. By the 5th of January, when their trial data monitoring committee met, they had data from 2,780 hospitalised patients. Around 750 of them had died, and more of them were in ICU receiving invasive mechanical ventilation, and another cohort receiving non-invasive ventilation. And if you added up all of those 7 studies that I showed you just now together, so the size of recovery is double and counting that of all of the other data that we have. Since they looked on the 5th of January, they've been recruiting patients at nearly 100 patients a day. So they're now well over 3,000 patients, and they're going to have another look at the data later this week because they have been told by their data monitoring that they need to keep recruiting because there isn't a clear signal yet. So the jury is still slightly out. That's what I meant about uncertainty for Tossi. Then what else don't we know about? Antibody therapies. You will probably again have heard lots about convalescent plasma, mainly from the United States, where without any clinical trial data whatsoever, just this registry paper, they decided to give it an emergency use authorization. Again, we don't know whether convalescent plasma works. And in fact, for certain groups of hospitalized patients, both recovery and REMAP-CAP have stopped randomizing, probably because they think it doesn't work. But we're waiting to hear for the data about the fact it doesn't work in those particular patients. Monoclonal antibodies are another thing that's been quite popular, mainly because Donald Trump received Regeneron when he had COVID. They're currently under investigation in the recovery trial, but it's from the data we've got, they seem to work quite well early on in the illness, but wouldn't work for people who are in intensive care. And Lilly have their own version of the Regeneron, so a different set of monoclonal antibodies targeting at the virus as Regeneron does, rather than the kind of monoclonal antibodies like anti-IL-6, which are anti-inflammatory ones. there's a whole plethora of other stuff in clinical trials, none of which we know whether it works. And so I guess the message for me is that clinical trials are absolutely essential. They're how we found what works. But so far we know steroids work. We've got a list of things we know definitely don't work. And there's still uncertainty around the other stuff, which is why we need to keep randomising. And if you had any follow-up questions after I disappeared, I thought you could use those to get hold of me if you wanted.
Wow, that was incredible. That was such a great run through. Thanks, Charlotte. A couple of points about remdesivir. So why are so many, apparently, centres in the UK still using it? And is it not effective at all?
So the centres are using it in the UK because it still, at present, remains in the NHS treatment guidance. Is it not effective at all? So I think there are probably patients for whom it is effective. So there is some small data that suggests if you are immunosuppressed, so such are the people who have recently had bone marrow transplants and have not engrafted and got a really good functional immune system, they don't clear the virus very well. And actually there's been success in treating patients who are in that setting with remdesivir as an antiviral. For the rest of people who are in hospital, probably by the time you've needed to come into hospital, you're not in the viral phase of the illness, you're in the my host response has got a bit wonky phase of the illness. And the problem with remdesivir is it's an intravenous infusion, so it's not exactly a drug that's easy to deploy out in the community.
So you've heavily mentioned research, and what struck a chord with one of the many sessions I've watched with you on, you said the only way out of this pandemic is through research and a vaccine. Now, I'm not an academic, I'm not a researcher. How incredible has this research been particularly from the UK, but as a global effort? I mean, can you just touch on that from your academic side?
Sure. So I think the first thing to say is that the majority of research in coronavirus has not been, and particularly in the UK, has not been delivered by academics. And that is the brilliant thing about it. I think when I looked today, there were 27,000 people who have been recruited into the recovery trial. So 27,000 people in the UK have been recruited whilst in hospital to a clinical trial. That is nothing short of astounding. But I guarantee you that the heavy lifting for that was not done by academics. It was done by clinicians every single day, committing to doing whatever they could to get us out of this. In the last year, because it's actually a year from, I think, yesterday, that the first sequence of the virus was identified and published by a couple of Chinese scientists. So we've gone from some people turned up in ICU with some weird pneumonia that we don't really understand, to finding a virus, sequencing it, developing 3 now licensed vaccines in the UK, found a whole load of treatments that work and a load that don't, you know, and we're not done yet. It's been amazing, but it's been done by everybody who's listening to this, not people like me in the main.
Thank you. In the final point, like I know you're dual trained, so you're respiratory intensive care medicine, but is this the future, respiratory intensive care medicine? You know, we've always been fans, we've always been in that zone, but is this the future now? Because the pressure is felt across all of respiratory medicine, community, front door, GPs. You know, what do we need to do to make sure we don't lose that?
So I think it's not about the silos in which we are. It's not that we've had anaesthesia and actually what we really need is respiratory medicine joined up. Actually, we need collaboration across the whole piece. It's not anybody's disease. It covers everything. You know, if you're an infectious disease specialist or a primary care physician or a practice nurse or community physio who's contributing to the rehab, there are not one of us that is not touched and vital to getting patients better from this. They're just odd. No one owns this disease. On a kind of respiratory ICU comment, I guess what I would say is that large sections of the rest of the world, the predominant specialty that lines up alongside intensive care medicine is respiratory. I used to work in the States, and there were a lot more people like me than there were anaesthetic intensivists. So it's not the same everywhere. And I'm sure Danny will know that actually in Australia, they've had intensivists for much longer than anywhere else in the world. If you ask them what their other specialty is, they will look at you like you're completely insane, because they just don't have one. We need everybody who's got the appropriate skills to be using those skills to make patients better, and worrying a bit less about which background they come from.
Well, on that note, thank you so much on behalf of all of the nurses and allied health professions and everyone else. You're such a strong advocate for the MDT. We are so grateful for everything you've done, your team's done, but you personally, and for joining us tonight. So thank you so much, Charlotte.
Really kind, thank you. I'm going to run away, sorry.
See you later, bye.
All right, bye.
So that was just a perfect summary of where we're at right now. I'm going to head straight down to Jonathan, who's an advanced critical care practitioner. Shout out to his podcasts. Oh my God, what a free learning resource he has. But Jonathan, what I'd like you to talk about is a little bit about your role as an advanced critical care practitioner, and obviously in the first wave compared to now, what similarities we're seeing, and we're seeing any changes in the patient demographics. Floor's yours.
Okay, so my role as an advanced critical care practitioner is, my background is as a nurse. I've since been trained in many other skills and attained a master's degree along the way. And I work alongside the junior doctors, taking care of the intensive care patients and taking referrals from around the hospital, be it ED or any of the wards, and dealing with the sick patients from start to finish, really. So getting to them and doing the things that intensive care do to patients on wards, and then taking them to intensive care if necessary, or leaving them there if we can do that as well. So that's my role. What's the similarities? There's lots of similarities. I'd say probably one of the main similarities for me is that working across boundaries becomes immensely important. That what has become evident, and certainly in the second wave for me as well, is that it's not who you are, it's what can you do. And that doesn't necessarily just mean what skills do you have that your job role entitles you to do, but can you draw up drugs? I don't care if you're a doctor. Can you draw up some drugs for the nurses who are struggling? One of the main differences for me, again, in the second wave is just the sheer number of patients that are coming through. We've already outstripped how many patients we had in the first wave, and it looks like we may be going further than that as well. So we've been in our operating theatres for a couple of weeks now. We've got we've got 3 ITUs where we would have had 2, and we've got a lot of nurses who are unwell, be it physically or psychologically. So as a consequence, for me, the biggest struggle that we're having, or the biggest struggle that the group is having, is amongst the nursing staff, who are working immensely hard. They're still trying to provide the care that they all want to provide each and every day. And with some of the help that's arrived to us over the past week or so, they are still able to do so. But there is a concern that if the patients keep coming in, are we going to start having to compromise some of that care? And that is a possibility. I don't necessarily say it's a probability, but it's certainly a possibility. The way we treat patients has changed, obviously. We have got things like dexamethasone. It sounds like, unlike some trusts, are not using remdesivir anymore. And the type of patients we are seeing, we are in we have a demographic of a large Asian population around our hospital. We're based in Bordesley Green in Birmingham, so we've got places like Yardley Green, which are very Asian heavy. And as a consequence, you can almost rubber stamp our patients. They'll be Asian, they'll be hypertensive, they'll be diabetic, and possibly they'll be overweight as well. And I would say that 70 to 80% of our population in intensive care are probably of that mix, whereas probably only 40% of the actual population in the area are of the same. So there is a heavy imbalance amongst that population. This is very anecdotal. I do feel like we are getting more younger patients, and we are getting more patients who don't have so many comorbidities. So we are getting your mid-40s patient with not necessarily any, I mean, we've had one or two with no comorbidities at all. Some of them have perhaps just got asthma. That seems to be a bit of a trend, but again, that's anecdotal. It could just be the way that I'm seeing it, and not a trend at all. The other thing that the nurses are feeling are a sense of they're becoming a bit dispirited, because it does feel to them like this lockdown is not really a lockdown in the true sense of the word. And I think some of the nurses, certainly when the clap was mooted a couple of weeks ago, there was a lot of muttering and mumblings in the coffee room that actually we don't want people to clap for us anymore. I think some of us perhaps didn't necessarily want it in the first place. What we want people to do is to realise how critical this is becoming. And I said to somebody for the first time some time ago that I'm genuinely frightened for the NHS now. I'm worried about where it's going to go, and how, for me, I feel mostly for the nursing staff, how they're going to cope now and in the future. And I think somebody like Dorothy and Julie Highfield, for example, could be testament to that the mental well-being of the nurses is at risk as well. But please, I don't just talk about nurses, I'm talking about all allied health professionals, because they've all been magnificent. We are working as a team. It does feel like there's I have a love of rugby, and it feels like we've gone on a rugby field with not 15 men, but with 10 men. But as a consequence, we're all pulling for each other, because we know that if we all work as hard as we can, then we've got still some chance of winning the second half, if you like.
Thank you. You talked about patient demographics there, Jonathan, a bit, and certainly from I could probably say from some of the research I've been doing with other centres is there's a much younger demographic, like you said, fitting well compared to the first wave.
Yeah.
And with late 20s to any age up, we're seeing a lot less in some centres of the very older population because of shielding, potentially because of the vaccine, who knows. Maybe it's probably too early to tell, but in terms of this virus can hit anyone, and I think in this, I personally think we're in a third wave. I know everyone keeps referring to the second wave, but it affects everybody. And some of the big high-profile clinicians, doctors, continuously saying treat yourself like you have COVID, treat everyone you meet like they have COVID. I think is absolutely the right way, because of what we're seeing in this wave is different again from what we've seen before.
Yeah, absolutely. And we are at the stage now where perhaps 3-4 weeks ago, we were getting patients, we were picking them up from the ward, from our respiratory ward. So they'd sit on the ward for X number of days. We'd hope not to bring them up, but ultimately some of them had to come up. Now we're getting to the stage where they're not even getting to the ward. They're coming into ED, and they are so sick in ED that we're just whisking them straight upstairs. There's no question to be asked. But we are finding, and without getting too political here, the definition of overwhelm for me is one that is become a political football, that you can define overwhelm however you like. But when you see the nurses working as hard as they can and the number of patients coming through the door, my version of overwhelm has been reached already. And I think a lot of the clinicians and the nurses feel that way as well.
And I think we'll definitely pick that up after Dorothy's session as well, with the human factor side of things for sure, and the impact of testing, and the fact of lateral flow testing and PCR testing, and isolating because of contacts, and all of this added workforce resource challenges that we're seeing in this wave. So thank you so much, Jonathan. Now, we've spoke a bit about the ITU nurse, but for those of you that don't know, the next panel member, Kate Tantam, the original rehab legend herself. Kate, do you want to come in and just tell us where we're at from an ICU nurse perspective?
I think John hit the nail on the head, really. I think a lot of the stuff that he said is stuff that I've heard from across the UK. We have had, so this week I was speaking to the kind of regional chairs for all the British Association of Critical Care Nurses to try and get everyone's views about where we were. And I think he's absolutely right. They're younger, they're sicker, and I think everyone is incredibly tired and scared. Scared, are we going to be able to keep going? Scared, are we going to have enough staff shifted? This is a, it's a shift to shift problem. This isn't we're not even, people are terrified about, next week, but we're also really worried about the night shift. We're also really worried about, are we going to be asked to open another 20, 40, 50, 60, 70 beds? Are we going to have enough staff to be able to support? Are we going to have bed buddies? Are we going to have people? I was trying to explain to one of my colleagues, they were trying to say, we're going to send you nurses, we're going to help. And I was trying to explain that you need people who are comfortable in the environment. You need people who are comfortable with the level of complexity of the patient. And you need to be able to support that person coming into the environment. So it's not like you can just say, oh, we'll have 10 extra nurses, because you can have somebody with 10 minutes, 10 months, or 10 years ICU experience. You need them to come in and to be calm, because it is such a difficult environment. And I think the other thing is that we're talking a lot about our red patients, but our green patients haven't gone away. So last time, I don't know about everyone else's centres, but lots of our centres that I've spoken to, the kind of people weren't having coronaries, people weren't going out and having big traumas. So the workload generally in the hospital, decreased because our other services were stopped, but our green workload reduced, and our green workload hasn't reduced. In fact, it's actually increasing. So you've got a normal ICU capacity, and then you've got a red ICU capacity, and then you've got extra staff, huge problems with staffing at different ratios. And I think everyone's just feeling that they're not able to give the level of care that they want to, because none of us are working in the NHS for any other reason apart from we fundamentally care about people and making it better and making people better. And I think the biggest challenge at the moment is it feels like we can't do enough, and that we're not giving the level of care that we aspire to. And I think that's really, really, really challenging for everyone's mental health. The other thing that I think is and I agree with you about it being kind of like, your third wave, God, I don't even know where we are in waves anymore. It just feels like a permanent tsunami. Is that actually still every day you have beautiful stories of patient recovery and beautiful, like we took a patient in the garden, and I know I whack on about gardens and humanizing ICU, but we took a patient in the garden, and he's a young man, so he's sub 40, and we took him in the garden, and he FaceTimed his partner, and I swear to God there wasn't a dry eye, because it's just the kind of stuff that we do because we know it makes a difference. And he got so much better, and his delirium got better. But the problem is we aren't able to do all of that nice stuff, all of that lovely patient humanization stuff at the moment, because it's just so busy. And I think that feels like the glue that so many of us use for our mental health. And I think when we can't give that level of care, it feels like we're doing everyone a disservice. So I think probably my feedback from the nursing teams would be everyone's tired, everyone's scared, and everyone just wants the general public to take it really seriously. And that actually every day, even when it's like MASH without the helicopters, it's kind of beautiful, isn't it? Because people turn up and they help, and you see teamwork in a way that I have never seen in my career before. So although it is the hardest time, it's also beautiful every day, because amazing things happen in a heartbeat. Like we moved 3 offices today and had to move 1 million different patients, and it just happened. I just went to people and said, help me, and they did. And that's cool. So that would be my feedback. It's hard, but it's amazing in so many other ways too.
Oh, thank you, Kate. I mean, you're always so passionate when you speak. I've known you for a long time now, but you can just feel the emotion. And I think you've spoken on behalf of every single intensive care nurse in the country right now, and probably everyone actually that is part of the critical care respiratory team. So thank you, Kate. We'll definitely come back to you. So Zoe, moving on to you from a critical care physiotherapy perspective. Now, we had a very quick text chat as prep for this, and we are actually seeing some changes, aren't we, in terms of not just the demographics of patients from a respiratory physiotherapy perspective, but what we're doing as a workforce. So.
Yeah, so you asked me, to talk about sort of the differences and the similarities for us this time round. I think differences, first of all, because there's less of them, is that there's more NIV in Optiflow this time round, and the IGNOC data from last week showed that actually that something like 24% of patients are being intubated within 24 hours as opposed to 54% last time round in the first wave. So we're using far more NIV and Optiflow this time round. Humidified circuits for us in Southampton, and I think from what I've seen on Slack, generally have become standard practice, which has meant for us that secretions are less of an issue, not an issue, but less of an issue than the first time around. And I'll come on to how that's helped us in a moment. And also self-proning for the self-ventilating patients has become sort of standard practice thanks to the ICS guidance, and we sort of laminate those sheets and give them out to any self-ventilating patient that is happy to accept them. So yeah, as we were talking about, Rachel, the big one really is that we've got less redeployed staff this time, and more patients. We've just had to think a little bit differently. Obviously, we've all had our times of feeling quite despondent over the last few weeks, but sort of have to pick ourselves up and dust ourselves off and just think differently. So as Kate said, you know, the green patients, these, we call them Novid at Southampton. The Novid patients are still there. It's still happening. The outpatient services are still running because they've all got really good at doing virtual stuff now. So we had loads of staff redeployed from MSK last time. Loads of staff redeployed from cystic fibrosis, but all of their clinics are still running virtually. So just less staff to be redeployed this time. So my team was 16 therapists strong in the first wave, and there are 4 core physios in this time around. We are getting some help from various people, but not really sort of static team members like last time. So what we did is we kind of had a little rethink about how we prioritize our resources, and hopefully, Kate, this sort of helps with the humanization aspect of what you were saying. The trachea weans became our #1 priority because we feel like that's where we can make the most difference to patients, both from a humanizing point of view, but also reducing their length of stay and improving their strength and all of those things. And chest referrals, obviously, from the nurses as well, are top of our priority list. After that, we see ventilated patients who have been ventilated for more than 7 days, because last time around, our sort of time to first active mobilization was around day 14. So we wanted to make sure we captured that group, to make sure we do the rehab with the ventilated patients. After that come the ventilated patients for more than 7 days. And then 4th on the list are the self-ventilating NIV patients, because the nurses are so fab with the self-proning. They just sort of look after themselves. What we did create is a little well-being checklist for those patients. So we gave out these little laminated cards. Are you able to get on your front? Are you in contact with your family? Can you get out on the commode? Is there anything else we can help with? Those sorts of things for the self-ventilating patients. And then other ways of sort of just thinking differently is other ways to use the wider multidisciplinary team. So we've started an AHP ward round. So myself, or the physio, sorry, the dietitian and the pharmacist will do a round either remotely or on the unit once a week. And also we have trachea practitioners now at Southampton. So they've been reviewing our trachea patients with us too. So that's all helped to improve the patient care that we're giving. And then other things we do with our staff, so the staff working from home, we've got onto databases and pickups tools and things like that. And we've got a great army of volunteers who come and volunteer for us on intensive care. And we've got them phoning from the outside, phoning the relatives and getting the patient profiles, so we know a bit more about our patients. And then we've got staff in the moderate risk group who can't go onto the unit, doing PPE training and hood training for the wider multidisciplinary team too. Similarities then, only a few of them. COVID still sucks, I think, is the biggest similarity. It's just as bad as it ever was. We're still seeing some spectacular desaturations during rehab on the edge of the bed with ventilated patients. So we still have to proceed with caution with these patients. They're very unpredictable. As Rachel said, we've got the full range of 22-year-old right through to 86-year-old, but they don't behave like 22-year-old and 86-year-olds doing rehab. You know, they're all doing slightly different things, and they've got a very unpredictable recovery trajectory, I'd say. And anxiety and fear still is very prevalent in our patients, the tubed awake patients and the non-invasive patients, because of the sharing bed spaces, the PPE, and just the breathlessness. It's just horrible to watch. So we're doing what we can to reduce anxiety in our patients as well.
Thank you. We're definitely going to talk about redeployment of staff. We're definitely going to talk about how we're managing the rehabilitation needs and about the added challenges of winter pressures having this wave in this period of time in the year, for sure. So there's loads of questions coming through in the chat. Please just, you do have to be signed into YouTube to use the chat box just to keep the trolls out. But please put any questions on there or through the social media channels. So Danni, over to you. Now, we have got a whole range of podcasts on all the different healthcare professionals that make up the MDT and that you'll find on this channel. Danni very kindly was part of those, and we talked about this incredible nutritional challenge that presented in the COVID-19 patient. What are you seeing in this wave? Similarities, differences? How has it affected you guys as dietitians?
Okay. I've made some notes, which is why I was typing on my phone before, so I wasn't texting anyone. I've made a few notes because obviously it's about similarities and differences, but it's not just about the patients, which is what other people have touched on today. I think that the fact that this group of patients and this wave of patients hit us so quickly and so intensely, and we knew they were coming, but we didn't know that they were coming in the way that they've come to us. So we didn't realize it was going to be as intense and as big an increase in admissions as it has been. So for that reason, as others have mentioned, we've still had surgeries going where we didn't have that last time. There's outpatient clinics still running where we didn't have that last time. So we have been really struggling, as have other professions, not just dietitians, with getting enough staff to cover the amount of patients that we have. And that's been our number one challenge. I had to cancel leave for myself and my team over Christmas, which was probably one of the most horrendous things that I've ever had to do. We're dealing with self-isolations and illness and side effects from vaccines and, people being off work that we really didn't see in that first wave. And again, that's across the board. So I think being able to just kind of keep up with the patient reviews in the same way that we did previously has been a real challenge for us. And that has a knock-on effect with mental health. Because similar to the first wave, I think one of the things I mentioned in one of the previous podcasts is that, yes, these patients have incredible nutritional needs, but so do the staff caring after them, not necessarily nutritional needs, but it takes a long time for us to review a patient because we're also trying to help the bedside nurses and the surge nurses by doing some bedside teaching, because some of these nurses have never, used a nasogastric feeding pump before. They've never had to aspirate a tube before. So everything just takes that little bit longer. And when you don't have the staff, that does make it more difficult because you want to be able to help as much as you possibly can. And interestingly, I think it's amazing. And again, as Jonathan said, I don't want to get political either, but it's amazing that the news crews have been allowed to come into intensive care units again and show what we're having to deal with. But sometimes I don't think that it does it justice because you cannot feel the fear and the exhaustion and the frustration of everyone's faces on the television. But you walk into an intensive care unit at the moment and it's palpable, you can feel it. And that has such a huge impact on people. So I think staff and mental health is probably one of the biggest differences that I've noticed last time, that kind of real energy and not teamwork. The teamwork is still there, but there's no oomph and there's no energy because everyone is so exhausted and frustrated. In terms of patient care, so we're still seeing the very, very high blood sugars and high insulin requirements that we did last time. That's difficult to manage from a feeding perspective and takes a real good amount of teamwork to deal with that. So pharmacist involvement, the nursing staff, the medical team, the dietitians. We would change feeding regimens because of that. We're seeing in this wave of patients a lot more feeding intolerance, I think, compared to what we saw last time. The NIV and the self-proning that Zoe mentioned has a real impact on patients' ability to manage enough nutrition orally. And often it's very difficult to get a nasogastric tube in because as soon as you take that NIV mask or the nasal cannula out, those patients desaturate. So being able to actually get a nasogastric tube in to be able to feed them enough is very difficult. And oftentimes, because they're at risk of having to be intubated, the medical team they want them to be nil by mouth because they may need to be intubated, quite rapidly. So that's having a huge impact on patients' nutrition intake because that's not hours, that's days that might go on for. So we're struggling a little bit with that at the moment, and just trying to find our feet. I think once we start to get all of our redeployed staff available, then that will really help. And just in terms of planning, I was just checking my notes. One of the things I think we need to be very mindful of is that we're in the very acute, from an ICU perspective, we're in the very acute phase at the moment where patients are staying a very long time in the intensive care unit, but many, if not most of those patients will step down to the ward at some point in time, and then they will go home. And we need to really be already thinking about that pathway and making sure that we have contingency plans in place for all of the AHPs to be able to manage their nutrition and their rehabilitation once they step down to the ward, and then also once they go home. So sadly, this wave, whatever number we're calling it, is going to be going on for quite some time, because these patients are going to have rehabilitation needs that are prolonged. And we need to be thinking about kind of redeployments to be able to manage that on step down too. So that's something that we've already started to think about. Yeah, so some differences and some similarities there from dietetics.
And do you know, one of the things I've learned so much from you is about your whole focus on education and empowerment, and that's what you say about, from a dietetic perspective, just spend that extra 15-20 minutes helping to educate the bedside nurse or the bedside support worker, the registered worker, whoever's been, like Jonathan said, being deployed in the critical care unit, because you never know when they might use that again, and if you miss that opportunity, then it's a missed opportunity. So that's one of the great things I learned from you, and that's transferable across the NIV machine, the CPAP machine, the feeding pump. Just take the time to spend. And I think, Danny, that's one of the hardest things, isn't it, in crisis management? But actually, the way, particularly having observed you do this in real life, like just saying, okay, let's just pause. Do you know how to flush that tube? Do you know why you need to do that? And I think that's so powerful, isn't it?
I think it's really key, particularly from dietitians, because, and I said this earlier in the year, and I think I only really properly realized this earlier in the year, is that as dietitians, we don't implement our own plans. So we write the plan and then off we go to the next patient, write another plan, and we expect the nursing staff to implement our plan for us. If they don't understand why we're asking them to do what they're doing, or if they don't understand how to do that, we can't expect that plan to be implemented properly when they have 1,000,000,001 other things to do. So I think that kind of bedside teaching and, as you say, empowerment and education is so, so, so important. And the nursing staff are so willing to learn. Like the surge nurses who are coming in from so many different places are utterly amazing, because it would be terrifying, and they're so willing to learn and ask questions. And yeah, it's amazing. I mean, every day they break my heart, and I'm not ashamed to say that I cried 3 times last week in front of my team, not because I'm upset for myself, but because I'm so heartbroken for the nursing staff and how utterly hard they are. And everyone is working hard, but the nursing staff, I think, have truly got it the worst, and they have not given up, and they, to me, are just unbelievably amazing.
Agreed. Well, thank you, Danny, and I'm sure there's I know there's quite a few dietitians on watching now, so please do put any nutritional slash dietetic questions in the chat. So Maria, moving over to you. I'm so chuffed, Maria, you can join us. So I think it's fair to say, and again, I'm dual trained, and adults and pediatrics, there has always and throughout this pandemic been a real focus on the critical care side of things. You know, it's truly horrific, the pressure on our critical care units, but the pressure on our respiratory wards and our respiratory support units, our emergency departments, is equally as, you know, tough. It's really tough out there. So from your perspective, from a respiratory nurse perspective, do you want to just give us a little update on where you guys are at?
Yeah, sure. So I had a little think about this in terms of lessons learned, where we were back in March and where we are now. And it does feel very, very different. So obviously we stopped a lot of the non-COVID work in the first wave. We concentrated and focused on COVID. You know, we had a lot of support from other areas. I think all but cancer work was held, whereby this time we're still, you know, utilising a lot of our non-COVID work, but trying to manage a surge as well at the moment. And then in terms of the sort of the respiratory side of it, so there's a lot of talk about respiratory support units at the moment, and I think, you know, whatever you want to call that, that's about delivering respiratory support in an area that's outside critical care. And I think, you know, that can be difficult in terms of the patients that you're managing on those wards are often not for escalation of care, so they're at their maximum level of care. Now, I think in the first wave, you know, and previously looking at other patients when we've thought about non-invasive ventilation, it was pretty clear cut who we were, you know, saying would be suitable for escalation of care, you know, perhaps, you know, wouldn't need the organ support in ITU, whereas now it's a bit different, and people that, you know, we might have been offering intensive care to, we're not anymore. And, you know, those patients that were saying that their respiratory support at a ward level would be their ceiling of care, you know, could be in their 50s, you know, they could be younger with comorbidities. And I think it feels very, very different to a lot of the respiratory teams that are working out there at the moment during this COVID pandemic. I think the respiratory nurses have really, you know, upped their game. You know, they're working really hard with high flow nasal oxygen, CPAP, non-invasive ventilation, which actually we're not getting as much non-invasive ventilation for the acute hypercapnic respiratory failures. I think if they're COVID ventilated patients, then it's very often type 1 respiratory failure. So these are new systems that the respiratory nurses are having to work with, and, you know, in very difficult circumstances because their staffing ratios are less, you know, they're kind of left to their own devices almost, because there isn't the sort of the medical and the multidisciplinary team support out there whilst the nurses are delivering this care. So I think it's definitely a challenge, and it does feel very different this time round. I think the benefits of, you know, what's happening at the moment in terms of support for patients, their families, for staff, is actually working really closely with other specialities. So we have an ICU MDT, we have a palliative care MDT, and it's really involving all levels of care to try and deliver the best care that we can in the most difficult of circumstances. And really not forgetting about our teams out there and how difficult that they are finding this at the moment, how frustrating, you know, they're seeing things when they're watching the news and they're seeing people that aren't distancing, yet they're still seeing this, you know, roll of people coming through the doors. So I think the psychological support, you know, can't be underestimated. And then the other thing I wanted to say was really working in an integrated care fashion. So actually, you know, we're doing that a lot better. So we're talking about COVID virtual wards, about oximetry at home. So trying to stop people coming into hospital if they don't need to come into hospital, but also trying to support people going home in an early supported discharge manner. So there's lots being done in respiratory care, and there's a lot of joined up thinking. You know, as I say, we like to work really closely with our intensive care colleagues, with our multidisciplinary team, the physios, the allied health professionals, the dietitians. You know, we're all working really closely as a team, and I think we have to continue to do this because this is going to get worse before it gets better. And I think we all need to look after ourselves so that we can deliver the most appropriate care to our patients.
Thank you, Maria, and thanks for speaking on behalf of the respiratory nurses, both, and I have to say across acute community, because there's a lot of admission avoidance work going on like never before. I think the community sector is really looking after preventing these patients coming into hospital. You know, across every pathway. But yeah, complete shout out. So, Pearlene, coming on to you, my lovely. So, you're going to talk to us about the respiratory physio, the good old specialist generalist.
Okay, I'll talk a little bit about sort of the demographics to mirror everybody. Really, we are seeing much younger patients. We were sort of used to the standard, the older COPD patients before, with COVID on top of it, and now we're seeing a lot younger patients. Their cough tends to be less secretions less of a burden this time, and a short of breath at rest and on mobility. But what we're seeing is a massive, rapid desaturation in our patients. And what's worrying is they are in the younger patient, that 40-year-old male, normally fit and well, healthy. And as a respiratory physiotherapist, we're used to seeing essentially desaturations in, like I said, the respiratory COPD patients, your ILD, advanced respiratory disease. But it's how we sort of deal with those patients. Like I said, these patients are asymptomatic, and it's basically just important that as a physiotherapist, when you're managing those patients, you're assessing the percentage drop and also having a look at the implications for rehab as well. In terms of management, we're seeing a lot more of, as Maria said, respiratory support units, and it is any unit that is potentially providing some respiratory care for some of our patients. So using non-invasive respiratory support, so whether it's CPAP, NIV, high flow nasal oxygen therapy as well. But as the respiratory units are also having the pressure of trying to deliver acute non-invasive ventilation to those type 2 respiratory failure patients as well. So we've kind of got pressures from the front door, the step downs from ITU as well. You've still got your regular COPD patients and your ILD patients, and then as well as trying to then deal with some patients who have long-term tracheostomies and laryngectomies, and it's a lot of pressure on the nurses and on the AHPs, and I am so proud of the team I work in and how well they've coped and worked together, and like I've been admiration of all of the nursing staff, all the respiratory nurses. But we've also, as AHPs, got to think about discharge planning and what we do as follow-ups for those patients, especially those who have high oxygen requirements. Because in the first wave, particularly, I don't know if you found the same, we weren't particularly discharging patients on long-term oxygen therapy. But this time round, we're kind of having to discharge them out just to ensure that they're getting a target saturations of above 94%. And these are in the younger patients. But the problem is, or the challenge is where do we follow them up? And, that's where the COVID outpatient clinics are an absolute godsend, essentially, and the setting up of those are going to be a massive and vital importance, especially for those patients with COVID pneumonitis. So in terms of sort of our lessons learned from sort of the first wave to the second and now third wave, I'd say the multidisciplinary team working is absolutely essential. We've got to absolutely draw upon the lessons we learned from the first wave to now. Communication is essential between all professions, SALT, dietetics, ICU, ID as well. We've got to remember the ID team across all trusts have done an absolutely fantastic job. But I think Charlotte said it earlier, it's everybody's disease, essentially. Everyone needs to take some responsibility to it and to react and cope as well as they possibly can with it, but equally to work together. Communicate with your staff. In the first wave we had a lot of redeployment, as I say, and essentially people took on a bit of a blended role. But we need to support each other and make sure that physiotherapist who's gone onto the ward to then to help with the nursing staff duties is also supported, so that they don't feel like they're on their own as a profession. Training is absolutely important and vital. For those physiotherapists, allied health professionals who have been redeployed onto different wards, just offering the basic respiratory training as much as possible and supporting them as much as possible. because that's absolutely important. And then I mentioned earlier about respiratory support units. That's a huge sort of lesson learned carrying on through. I'm working with the BTS working group, or RSU working group, led by Ben Messer, to create some guidance, because there's a lot of respiratory support units out there. Because what was evident is people were getting, whether it's NIV in any form, whether it's CPAP, HFDO, little pockets of one wards, but not really particularly governed by anything or any guidance out there. So we were trying to provide some support to them. That's my little BTS plug, really. But basically what I'm trying to say is we have massively noticed a difference in the demographic change of patients, but equally as a respiratory unit, we're dealing with 3 different sorts. We've got the step down from ITU, our regular patients, and patients still coming in through the front door to try and cope with.
Thank you. Loads of information there, but you made a good point about the respiratory support units, and there's been some comments in the chat about the complexity of the patients this time round, the amount of high flow CPAP are using, the nutritional challenges that brings, like Danny mentioned, but really these patients are awake and they know there's a high likelihood they may not survive. You only have to turn the TV on to have data thrown at you every day. And I think that, moving nicely on to Dorothy, is one of the additional challenges that we have in this wave we didn't have in the first. We didn't know what it looked like. Now we know what it looks like and we're reliving it. And surely the psychological burden on that, whether we consciously or subconsciously are aware of it, Dorothy, because I think, speaking personally, someone who can compartmentalize and think, I'm just going to get through this, I'm on the treadmill, I'm not getting off, I keep going, I'll just keep phoning my friends and I'll keep doing stuff like this. It's like, when, what impact has that had? So Dorothy, you've got the final session in terms of giving us an update, but really, could you just try and bring together the whole, patient, family, staff element of this wave? Thank you.
Yeah, thank you, Rachel. So I'm a health psychologist working in critical care, and I'm also helped to run a group called Pink UK, and that represents all the psychologists working in critical care. And we started off as a really tiny group, and we are sort of growing a bit now. We're more than 50 now. And I think, the sort of good and bad news is that COVID, I think, has brought about a lot of hospitals now thinking, we actually do need psychologists in critical care. That still probably leaves about 250 cancer cases that don't have psychologists. And without being sort of self-aggrandizing, I really sort of wonder how those critical care units are coping, because what we've noticed is that as soon as, with each wave, we suddenly will get, there's 2 of us now, 2 psychologists, we suddenly just get a massive tsunami of referrals, patient referrals, family referrals, staff referrals, because as you rightly say, everyone is under a huge amount of stress, and there's a huge amount of anxiety in all those 3 groups. And it is quite difficult to prioritize, because you can't really, if you focus on the patients, then you become aware about the staff. And if you focus on the staff, then you become very worried about the families. So we just have to try to balance looking at the issues for all those 3 groups. So for the patients, just in terms of differences, I think maybe because we're in central London, haven't noticed that much difference in the patient group. So we always had really young, it's always been really hard for the staff, because we've always had really young patients. From the very beginning, people were shocked at having, young patients dying in the unit in the early weeks of the first wave. And again, because of central London, we've had we've seen a lot of Black and minority ethnic patients, and a lot of sort of middle-aged male patients as well. So all groups that you don't want to see struggling to that extent. So I think, as everyone said, for the awake patients on CPAP, Optiflow and NIV, then obviously anxiety and fear is the major issue. for the patients who've been intubated and sedated, which we still have a lot, once they start to wake up, then I'd say delirium is really one of the big key issues, always in critical care, but particularly with COVID. I think it's partly because there's the lack of staff, usual staff time that might be spent reassuring and reorientating patients. It can be a very even more confusing environment than usual during the pandemic, with all the staff in PPE in slightly makeshift conditions, and of course not having families there to hold the patient's hand and reorientate them and sort of create that meaning and reality for them. Then for the patients, again, as they might become less delirious and more orientated, but then they seem to go into a phase where they're quite drowsy, confused, and they talk about the brain fog we often hear about. So that can be very difficult. Then when they come through that, then they, like the CPAP patients and so on, they become very, very anxious and frightened as they realize what they're struggling with, as they know they've got the virus, they have the breathlessness, and they just look around them and see all these other patients struggling along like them. And then finally, I think, unfortunately, it can become, you start to realize that rehabilitation, especially for intubated patients, is a very long, slow process, and you're going to be in hospital. People are in hospital a long time, so then they become very low because of the long hospitalization, frustrated. They can't understand why they can't make progress more quickly. And then post-hospital, we do see quite high incidence of post-traumatic stress disorder because they've seen so many frightening things in the hospital. Some people are quite depressed, and people remain very anxious. They become very anxious about their health. They're very frightened about getting COVID again, and just generally about being ill again. And then many of them have to adjust to, real changes in their life, disabilities, and the fact that, we had some, for example, we had a very fit middle-aged sportsman who's now struggles to walk a few feet with oxygen. He is back at home, but, his life is completely different, and patients obviously need support to deal with that. And I've been quite involved in some of the work on post-COVID rehabilitation, for example, developing websites like your COVID recovery website, an interactive site. As people said, it is fantastic. There's been these announcements about post-COVID services, but it's slightly worrying that just as they were announced, we then are hit with this huge second wave. I'm just kind of wondering what's going to happen to those clinics. Are those staff actually now being redeployed back to acute work? We did do a follow-up clinic, for example, this morning. We're trying to keep going with our follow-up clinics to see those. We're still seeing through the COVID patients from the first wave, but will we be able to continue with that as we get busier and busier in the hospital? I don't know if other people are managing to keep up with the clinics. It'll be interesting to hear. So I think in terms of the patient, I think the most important thing, I think several of you have talked about this, but I think it's just keeping the human touch in there, in the treatment, in the ICU, because it's such a frightening place at the moment. It's such a terrifying experience, but it can just really help if staff somehow can find the time and the sort of human energy, I suppose, to keep relating to people, to introduce themselves, to explain what they're doing, why they're doing it. It's often having to just explain where you are, why we're all wearing this strange PPE equipment, helping, making sure that patients feel safe, trying to help them feel safe, thinking about your tone of voice and your approach to them, although you might be in a rush, perhaps trying not to appear too rushed. But I know that's all a big ask at the moment, but I think all that is really, really important. And then the things that we try to do really well in other times, that sort of non-pharmacological delirium protocols, we are kind of focusing very much on that at the moment and putting up some sort of posters of top tips to deal with delirium, but just remembering about people's hearing aids, glasses, need for daylight, need for sleep, be in touch with their families, even though their families aren't there, having some familiar things around them. So although the families aren't there, we can get things sent in by the families. We can get families to email in pictures other things that will just help the patients. And still radios, iPads, etc. for entertainment and distraction, because I think there are too many patients that are just lying there day after day, feeling extremely frightened and not having much contact or anything to distract them from the worry. So yeah, we talked about families. I think in some ways we're doing better with families this time around than last time around, because I think last time it took a long time to sort of work out what to do about the families. They were just told they couldn't come in, and it took quite a long time, but we did set up a family liaison team, as I know lots of people did, and that family liaison team now is going really strong. We've got a lot of people, a lot of volunteers from surgeons and dentists and all sorts of people who are running the family liaison team. So they make sure that families get regular video calls with the patients, and where families come in, where they're allowed to come in, then the family liaison team are sort of helping the families through those visits. But obviously it's a really anxious time for families. They're separated from their loved ones in hospital. They've got there's a lot of anxiety around getting their medical updates every day. They get very worried if they don't get it, but at the same time, the staff are sometimes struggling to keep up with all the updates. And obviously there's a lot of fear because of what we know about coronavirus, about whether the patients will survive. So along with our family liaison team, we've sort of set up behind that like a sort of family support team. So families who are very, very anxious and really distressed and not coping, they can be referred either to psychology, palliative care or chaplaincy, depending on the issue. Also child psychiatrists, child psychologists who volunteered to help support the children. So obviously with all these young or middle-aged people, many of them have children who may or may not really understand what's going on. Okay, so I think those are the main issues about families, and then everyone has talked a lot about the staff, and I think the biggest change this time is the impact on the staff. Obviously the first wave had a big impact on the staff already, and now staff are having to go back and do the same thing when they're already tired, they're already stressed, and just having to go through knowing what they're facing and having to go through it. And as has been pointed out already, because a lot of staff have been ill either physically or mentally, or may have COVID, or may have to be self-isolating because they've been in contact with other people with COVID, then that's created huge shortages and even more strain on the staff who are there. And then I think when talking about staff, I think we tend to talk about it as if everyone's the same, but there's a lot of different staff groups. There are a lot of different stresses. There's the stress related to ITU nurses. We know that they're under more pressure than anyone. But then it's also very stressful to be redeployed staff, nurses or other staff coming in to help and really not feeling not being used to that environment and not really knowing what to do in that environment. And sometimes being made to feel really welcome and sometimes not being made to feel so welcome when it's a bad day and everyone's really stressed and impatient, which I think can happen. Then there are other people who are shielding or not well, and they feel, oh, I'm not even, they feel distant from the team. They know everyone else is involved in this heroic effort and they want to help, but they have to either stay in safer areas or stay at home. So I think obviously some units have psychologists, but hopefully other units, if they don't have psychologists, they're getting access to psychologists. I think there are quite a lot of redeployed psychologists or psychologists whose services are not running in quite the normal way at the moment, who can help out with staff support. And there's so many different interventions depending on how people are. And again, not everyone is the same. Not everyone is, in this really difficult state. Some people, I've seen some people being quite energized, still feeling quite energized at the moment, feeling quite confident that they know what they're doing. And I think maybe, what Charlotte was telling us about, perhaps we all feel a bit more confident about some of the treatments and the difference between realizing that perhaps we can use NIV more than having to ventilate everyone, which seemed to happen at the beginning of the last time. So there is confidence as well, but then in other cases people are extremely stressed. Some people are having panic attacks when they go back to the same areas that they worked in the last time. Some people having flashbacks, memories to really difficult experiences. So we kind of need support and interventions from everyone that could range from just information on well-being and self-care. Sometimes when we're just really busy, we just forget about the self-care. So it's just reminding everyone to look after themselves so that they can help look after other people. You can sort of direct people to useful well-being websites, apps like Headspace, Sleepio, and lots of other ones which are free for NHS staff to use at the moment. Then we have helplines such as the NHS People Helpline, which has got a huge range of services actually, which is really, really good. Then, in the hospital, some people will ask for one-to-one informal support. Others want, more intensive counselling, maybe from their occupational health or staff psychology, and other people might prefer to, get advice on how to go to their GP and self-refer themselves to community psychology if they need that extra level of support.
Thank you, Dorothy, for such a comprehensive summary and for all your thoughts. We do have some specific questions in the chat, but I want to bring Jonathan and Kate in at this point because you've touched on the redeployment of staff. And for me, as Zoe said, as allied health professionals and to some degree nurses, all existing services should and must continue, especially priority services. And because we can now do so many more services remote, we have virtual platforms, we're not seeing the people en masse turn up. But when people do say, look, I'm here and I can help, how can we protect them in this wave? Like, what strategies do we have for people either coming into the intensive care unit that will move on to because it's really about red zones, isn't it? It's about being in full PPE. It's about looking after patients who are critically unwell and who may not survive, and that psychological burden that comes with that. Jonathan, maybe over to you first.
I think there's a number of strategies that could be employed to help those people who actually walk into the intensive care cope with some of the scenes that they might see. Some of those to be implemented are going to be difficult now. They perhaps should have been implemented earlier. I know that we, for example, started a reservist training probably 3 months ago. But I think at the time we weren't really aware of what we were going to be facing, because I'm genuinely surprised by how bad this has got. I didn't expect it to be worse than the first time. We all knew that post-Christmas was going to be difficult. We all expected that. We all knew that probably it was going to be a little bit worse than pre-Christmas, but not to this degree. So maybe there was not a complacency, because I don't want to use a word as strong as that, but maybe we weren't quite as good as we should have been at preparing for something else that was going to hit us in the future. And I think if one lesson can be learnt from this pandemic, both amongst the nurses I work with and the nurses nationwide and the allied health professionals nationwide, is that we need to push as a group to ensure that we as a group have a stronger and louder voice in the nation's healthcare and in the direction it takes. I think sometimes we have been, this may sound a little strong, but I think sometimes we have become a little passive in not promoting the thing that we do each and every day. And if we had been a little bit more aware of that, then perhaps we could have been a stronger voice. I think the other thing that, from a more local point of view, one of the things that we can do, and something that I always try and do, is to smile, say thank you, introduce myself, and let people know that we are grateful for their help, that they should always ask questions. And if they don't know how to do something, please don't do it, because we are there to guide them through that process. And if it's not something they're prepared to do, that's not something I'm prepared to make them do. You know, it's an incredibly scary environment. If you put me in a, I don't know, if you put me in a pediatric ward, I'd be terrified as well. And just an orientation is something that could help those nurses, those support workers as they come through. And it's like I said at the beginning, and I do believe this very firmly, that there are some professionals coming into ITU to help that seem to believe that that help is only within their professional domain as it stands, as their title gives them. So if you ask somebody to go to the nurse's bedside and perhaps just draw up some infusions, it's not an appropriate answer for that person to say, well, that's not something, somebody else normally does that for me. And again, go back to that phrase, it's not what or who I am, it's what can I do to help. If you were on a disaster scene, let's say you're on a motorway and there was a big accident and you weren't a healthcare professional and you saw somebody struggling to get out of the car, would you stand, can't help them get out of the car because this is not something I've ever done before? If somebody's prepared to help me and show me how to help this person, then that should be something that I get involved with. And I would say 95% of the people who are coming to ITU do that. I think cross-boundary working is something we should also be doing. I think the way we train from an intensive care point of view, I think the way we train is wrong. I think we should be training together, not apart. I think respiratory physiotherapists, I think dietitians, I think speech and language therapists should have a core part of their training as part of the intensive care so that we all work and train together. Danni talks about some of the things that she does as a dietitian. I probably read more than most as far as the world of ITU goes, but I don't necessarily have a full insight into what Danni can offer, the things that she can do that can help my patient. And I think that's probably true for a lot of the other professions, that you don't know necessarily what I can offer. I don't know what you offer. And I think that goes back to some core training that could be incorporated in all of our programs. If you want to specialize in intensive care, it's not just about specializing in nursing, it's about specializing in dietetics, speech and language, physiotherapy, because that's something that we should all have a basic understanding of, and indeed a greater understanding of. So for me, that would be some of the key things to do.
Thank you. I'm definitely going to bring in students. Kate, I'm going to come to you then. Pearlene, coming to you. Kate.
So stuff that we've done to support our redeployed staff is we had a Rise Up program that we put people through that taught them kind of clinical stuff like pumps and proning and kind of basic things, you know, basic things that we needed in wave one. And then we've also, we've allocated a practice educator to each of the areas, because we think having a practice, so we use the CLAP guidelines, I don't know if anyone saw it, which is the information about supporting staff, that the lessons learned during the first wave. And so we employ a lot of that across our areas, and we've got practice educators helping and supporting staff. And we have a lot of kind of buddying up and supporting staff with a bit of sim and a bit of, and a rotational actually. So trying to get buddied staff and support staff to rotate through COVID and non-COVID areas to try and give them some time off and to give them some support, and making sure they're with people that they know and that they've worked with. But I think John's point about just saying hello to people, introducing yourself and saying thank you so very much for being here and for turning up and for, you know, for supporting the team. But I also completely agree with this point about blended roles. So we've been really lucky with our rehab team. We've had a red respiratory rehab and discharge team, and we've had every member of the MDT, including nursing there, going, and psychology, talking to every patient and supporting people who are coming into the team. And it's been a very rotational team, and our demand has therefore been able to flex to, this ward's had 20 admissions, go there via WhatsApp, you know. So it's allowed us all to be quite dynamic and quite supportive. But I absolutely agree that this is a, you know, this is a team, this is, everyone has something to bring to this party to be able to make it better. And of the redeployed staff, I think if you can support them really early on and make them feel loved and supported and just so grateful that they're helping and that they're there. And even if, you know, even if it's just getting sheets and getting infusions and helping stock up, it doesn't matter actually what anyone, like admin, we had people coming in to do admin support. It doesn't matter what anyone does. It matters that you've turned up and that you're there, and that anything you can do is helpful. But actually we can all be outside of our professional box a bit, can't we? So we can support doing rehab if you're, you know, if you're a physio and you've been redeployed there, right, okay, let's do a bit of a limb check at the same time as, I don't know, you know, it's about being different and being a bit dynamic about our roles. But I think the really easiest thing to do is just be really nice to everyone and say thank you and offer them the support that you would want if you were in their shoes.
Mm-hmm. And that's why I just love the name badges, you know, the written badges on, however you want to do, felt tip pen, sticky, healthcare support workers, like whatever you want to call yourself. If you're not in there as your professional role, identify yourself as someone that is there to support, because generally people will just grab you, people will be like, oh, can you give us a hand at bed space? And that's what it is, isn't it? It's maybe like the boundaries. And if you are there to be the physio or the dietitian or the speechy or the OT or the ACCP, like they'll know, because it is a situation in intensive care units where you're working with someone you've never worked with before. And that's what we've never quite had before as part of an ICU or respiratory family. You kind of know everyone, especially on a respiratory ward. It's like, who are you? What are you here for? Are you the orthopod? So yeah, Pearlene, I know you had your hand up.
Sorry, I just wanted to kind of expand a bit on Jonathan's point about sort of blended roles, but I don't want to forget students in there as well. We still have students and also brand new junior, whether occupational therapists, physiotherapists, dietitians. It's just making them feel welcome, because they've not been in an acute environment in COVID before. Most of them haven't. They will now. That brand new year will know COVID-19 as their normal now. But it's also just making sure we're supporting them for what might seem as a little worry about they potentially have some, like they've got a background of asthma. It's talking to them and making sure that they're okay and understanding that we have PPE, just little bits of talking to them, supporting them and smiling, saying thank you. That they all seem really simple things, but it makes a huge difference to them. And I just wanted to say at that point really is just making sure that we are looking after our students and our brand new physios and OTs, doctors, dietitians, nurses, all of them.
So students is something that I want to bring up. It's come out, there's quite a few students that have joined tonight and quite a few students in the chat. So this can be for Dorothy and everyone. So there's been a specific comment around our students' burden, their burden at the minute. Now, I am an honorary student president and I have to say absolutely not. It goes back to Jonathan's point about knowing what your role is. Rather than wanting to be spoon-fed information, wanting to learn about blood gases in the, cardiovascular system, you go in there and say, I am here, I am willing, I am able, this is what I can do, this is what I can't do. And it's just feeling part of that team. So for my thing, for any of you professionals out there listening that haven't got students, get yourself some students out, get them en masse, get them in teams of 10. So they can all buddy up. Space is a real issue with social distancing. I totally get that. It's a real issue. But going back to kind of what Danny said and what John said, like it's not a full-time placement. We're giving students opportunity to work in a pandemic as well as part of this MDT that we'll have like never before is so important. Jonathan.
I just wanted to say, because I know that everyone on this panel is passionate about educating those behind us, if you like. That's the reason why we're here. We wouldn't be spending our evening doing this if we weren't. And one of the greatest pleasures I get is to have a student nurse come up to me and start asking me questions, not about blood gases, not about the complicated stuff. We can do that later, but ask me the simple questions or show me some interest. And you know what? This may sound a bit perverse, but in a funny way, this is probably one of the best recruitment opportunities that intensive care have ever had. Because if we show these people how we work together together as a team, if we show them how we can care for the acutely sick patient and in a remote way their families, if we can show them how we can do that and work so well together, then hopefully we'll get a lot more ITU nurses of the future. And students, bring them on, please bring them on, ask us questions, because in all the grind and the suffering that we experience, we still want to be teachers, we still want to be mentors, and we still want to inspire people. So if you see me in an ITU, and I'm fairly obvious from the bald head, everybody knows me there. If you see me in an ITU, come and ask me questions, come and follow me around if you like, that's fine as well. We can find jobs to do as a team, and I'll teach you at the same time, and I will inspire you as well.
And learning from this pandemic, we have to, like you said, those traditional hierarchical, you know, you're only you're a speech and language therapist, so you have to do this and you have to do that. It's moving away from that. Like you said, if we're going to really work in multi-professional models, you know, we'll have to work as we would work from now on. So I completely agree, completely. There is core competencies, I get that, and there is things that we'll have to learn as students, but really this is the time for change. So Dorothy, I don't know if you want to add anything onto that from your perspective, or whether we've nailed it. Looking after students as well.
Yeah, I suppose my only point would be, I mean, yes, it is great. It's fantastic to have them there, and you know, they can be really helpful. But I do think we have to think about the potential impact on them when they first come into that environment, and that we can't just throw them in there and sort of sink or swim. So I just don't know what kind of interested in knowing what kind of inductions are being done. Some of my colleagues have sort of consulted me about that, and I'm suggesting maybe sometimes having some training videos to really familiarize themselves with the sort of what the ICU is about, and seeing it in a slightly less threatening way on a training video, and then maybe even taking them to areas where there are not yet any patients, where they can see the beds and the equipment. Because I just think there's something when you walk into a full bay in an ICU with all the ventilated patients, it can be very traumatic.
Absolutely, the e-learning for health modules. The e-learning for health modules are absolutely fantastic for that. I think you've hit the nail on the head. For me, there's power in numbers with students about, you know, knowing that they're not the only one, and students should be treated like any other member of staff. So in my opinion, obviously fit tested, lateral flow testing, and PCR testing, and of course now the vaccine as well. So I know some people might find that controversial, but it's absolutely true. They're part of our workforce, they're part of the next generation of workforce. So, you know, definitely kudos. So Pearlene, and then I'm going to move on.
It's just for those students. We were all there once. We were all students once, and we all remember what it was like, and we'll always support you as much as we possibly can.
Thank you. Now, Danny, there's a question we're going to move on to some specific questions. Danny, there's quite a few questions for you actually, about how can we nutritionally optimize patients when they can't get NG tubes in? Is there any quick fixes? There's the questions around PN as well.
Mm-hmm.
An option.
I definitely know these questions are not from my team who are listening. Hi, team. Yeah, it is really, really, really difficult at the moment. And I know that some places are implementing a standard oral nutrition support protocol for any patient who's on NIV or who will be self-proning. So rather than waiting for a referral to the dietitian, those patients automatically get prescribed oral nutrition support 3 times a day. And if that's all they take, then at least they're managing something. Certainly in the first wave, there was lots of talk about whether or not using peripheral parenteral nutrition might be an option in these patients. And again, that the discussion has come up again. Most centres in the UK don't allow peripheral parenteral nutrition at all. So that's probably not a great option. My view is, and has always been, that it doesn't matter to me how the patient gets nutrition as long as they get it. And if you know that that patient is going to be on NIV for 2 weeks, or you know they're heading more than a week, then I can't see why you wouldn't give them parenteral nutrition if you cannot get a feeding tube in. and if they are not managing their intake. That's my view. That is probably quite a controversial view. But at the end of the day, that patient needs nutrition, and nutrition is not an adjunct. Oh, you only get it if you can. It's actually part of that patient's treatment. And one of the downsides of nutrition is that you don't see the detrimental effects of poor nutrition in an hour. You see it in weeks. So if you wait, it's too late. And so actually, I personally would think that if a patient absolutely cannot, there's no access from an enteral perspective, and they are unable to manage their requirements, then yeah, I would be pushing for PM after a week in those patients for sure.
Thank you. You just answered another question in one. Now, this is from our friend Rob. Hi, Rob.
Hi, Rob.
So he's seeing more patients with who are unable to move their bowels for prolonged periods despite laxatives. I am seeing this, and particularly in the CPAP patients, and it's a real problem for them because of desaturations, shortness of breath, everything that comes with COVID. Why is this? Did we just miss it in the first wave? Is it more prevalent? What do you think?
So I am not necessarily seeing it in the patients who are on NIV, but that's because I'm not seeing that many patients necessarily on NIV. We're early intubators. But I am seeing it a lot in the intubated patients, most likely because of high levels of sedation and paralysis. Many of the patients have had a really poor oral intake before they come into hospital, and then they have a poor oral intake whilst they're in hospital. So what are they going to move? They've got nothing going in, so there's going to be barely anything coming out. So I think that's probably a problem. That to me is a really important sign that actually these patients' nutrition has probably been poor for some time. And yeah, I mean, it's an issue. I mean, laxatives are not working. Yeah, it's a problem. And I think it comes down to adequate nutrition. Probably in the CPAP patient, in the intubated patient, I think it's more to do with gut motility, paralysis, and sedation.
And we did kind of see that in the first wave, didn't we? But maybe it was more because we had more ventilated patients than non-invasive.
Yeah, so that to me in the ventilated patients hasn't changed. That's the same. Yeah, but in the non-ventilated patients, it sounds like from kind of Rob's question that might be different to the first wave.
And just a final question, there is a couple more questions for you, but just for this one, has your dietetic practice changed in a sentence in this wave?
No.
Thank you so much.
That's all right.
Zoe, coming down to you next, how are you managing rehabilitation with these patients in terms of desaturations, the complexities that exist with them?
So just taking any precautions we can. So pre-oxygenate before you move them, pre-oxygenate throughout if you need to. So we're not hyperoxygenating, so we're not doing it willy-nilly, but if the patient needs to maintain sats of 92, 93, 94, then we will put their oxygen up. We often put the pressure support up as well to support them during the rehab. And also what we learned from Surge 1 is that if you have a patient going between non-invasive ventilation and self-ventilation, because they're weaning, then you would always do the rehab on the highest level of ventilation that they're on. Because I had a patient who was extubated in the morning and went on to NIV, and because he wanted to talk to me and because I wanted to get to know him, I took his mask off while we did the rehab, and that was a big mistake. And he got reintubated in the afternoon. He did go on to do all right in the end. But that was a real learning curve for us. So yeah, definitely rehab on the highest level of ventilation you can.
I think it's the combined fatigue and any small demand that's placed on these patients in the weaning phase. It's like something we've never seen. And actually what's been interesting in this wave, and please anyone jump in here if they think this isn't a reflection on what they've seen, is actually we're seeing more of a shift towards concentrating on the rehabilitation of the patients because the secretion load isn't quite what we're seeing in the first wave. So we didn't expect it, we got it. But this time it's more that how can we effectively wean them? We might take the tube out of them on the ventilator, and we don't appreciate the work of breathing demands, the fatigue demands. It's like nothing we've seen in terms of that weaning phase. Would you say that's reflective?
It's the anxiety that goes alongside it as well when they feel breathless on the edge of the bed, and it all gets mixed up in their heads of quite how horrendous they feel. So it's a combination of their psychology and their physical state, because the colour drains from them, they bleed, sweat, you know, it's horrible to watch. You sort of think, am I actually doing harm here? You know, as a massive advocate of early rehab, I have thought to myself with a few patients in this wave, you know, is this the right thing to do? But alongside some breathing control and some reassurance, and, you know, I'm not being flippant about this, you know, it takes a long time and it's not easy to reduce the anxiety in these patients, but it's definitely multifactorial. And, you know, when you see their CT scans as well, you can totally see why they're breathless on the edge of the bed.
Absolutely, and I think that the further complicating factors, we had a talk, Pathophysiology of COVID, from Dr. Bridge Patel, that was so interesting and insightful in terms of thromboembolic disease and all of the consequences of COVID in this wave that we didn't quite see, probably to this extent, like you said, in the first wave. So, and I think this is where, for me, it's what is your value when you're thinking about redeploying your staff. So what is the added value if you have physiotherapeutic skills, not necessarily physio, but if you have those like rehab handling skills, being able to assess when someone is getting fatigued to the point where they get fatigued, because once your patient's desaturating and they're in trouble, they're already there. For me, that's the added value rather than going supporting elsewhere. So with my manager head on, that's certainly something that I say to teams when they're reaching out for advice about where do they redeploy their staff. Think, well, what skills and ability do you have? And that will, when you've got a nursing ratio of 1-to-1, it's okay because the nurses can help you and they can be there. But when your nursing ratio is 1-to-4 and you still need to get these patients moving, that's when you need those extra pair of hands, isn't it?
I'd say as well, as physios, we are born motivators. And I think no matter what your background in physiotherapy, where you are redeployed to ITU, you can motivate the staff, you can motivate the patients, you can come bumbling on with balloons and games and whatever it is to just cheer everybody up a little bit and just brighten the day a little bit. And we always say at the end of your treatment session, ask the nurse, is there anything else I can do while I'm here? Just to make sure that you can do as much as possible to let the nurses get their breaks and things.
Thank you. Now, Maria, moving over to you for the NIV CPAP patients and the respiratory support units and the HDU units. We're seeing, one nursing staff for 6, 7, 8 patients on non-invasive CPAP support. Where do you even start from your care perspective?
It's a real struggle. Especially when the patients are first going on to their non-invasive ventilation, you need a lot of hands on deck to start with. And just the monitoring of patients, making sure that the patients are getting their medication, that they're getting their nutrition and their fluids. It is a struggle. I think respiratory nurses have been working in that way for some time, but I think when we're looking at redeployed staff, trying to support them to support our patients, again, can be quite overwhelming. Those ratios are quite difficult when you've got, 8, 10, 12 patients on non-invasive ventilatory support, and you've probably got 2 or 3 nurses, if you're lucky. On a night shift, probably less as well. I think it's difficult from a patient's perspective because, they probably feel like they're not getting as much support as they had in intensive care. They feel frightened. It can be a very difficult situation, and one that we just try and manage on a day-to-day basis. Looking at how many patients that we've got on respiratory support and trying to think about where's best to place the experienced respiratory nursing staff, what sort of support we would need, utilising, other specialities, other multi-professionals, just trying to get as much support as we can, but it can be very difficult, and it can be difficult for, patients, staff, relatives, especially if they've stepped down from intensive care when their ratios may have been higher.
Thank you, Maria. Pearlene, coming to you about questions about how we manage infection risk on the wards using NIV and high flow. I know you'll probably reference the BTS, very helpful guidance with pictures and things on this, but I mean, it is a worry. Now I think there's more confidence in NIV, either being cast still as an AGP, so wearing full personal protective equipment, but what are you guys doing to manage the risk?
Oh, sorry. So as you mentioned there, ensuring that we've got the highest level of PPE as needed for AGP. Equally, just if you noticed a bit earlier on in the year, last year, the BTS published guidance on what to use for setup in terms of CPAP and NIV. So using a tube, non-vetting mask, ensuring that you have filters at the patient end. In terms of high flow, but to be honest, I'm not really familiar with all the high flow patients. My experience is more with CPAP NIV at the moment, so sorry, I can't particularly answer that question. But making sure that you're changing the circuit every 7 days and the filters every 24 hours is going to help reduce the risk of infection. The other thing, if possible, for those who have really good links with their estates, is seeing if they can test the air change time, because that will give a really good guidance for those patients who are potentially weaning off NIV, in terms of if you've been off for like an hour or so, to minimise using wasting any PPE. They can then go into those rooms after say an hour, depending on what that says for the air changes. But it's just trying to minimise the amount of infection risk that way, really.
Thank you. Now, a few questions about PEEP. So I presume this is in invasive ventilation and non-invasive ventilation. In terms of, if we think back to the first wave, we were hearing these, incredibly high levels of PEEP needed for recruitment. We didn't see that so much in the UK demographic in the first wave. In this wave, I have to say a standard would be to start someone on a PEEP of 10 of CPAP. In my experience, I don't know, Pearlene, Zoe, Jonathan, if you want to come in there. Maria, in terms of invasive, non-invasive, what are you guys seeing?
In terms of, for CPAP in non-invasive, definitely I agree with you there. CPAP of 10. I would definitely agree with starting with that. Anything below is just probably going to be not as effective or clinically effective, essentially. My view on CPAP.
Thank you, Jonathan. Oh, sorry, that was my fault. I clicked here by accident. Oh, Jonathan.
Are you being rude to me again, Rachel? Yeah. You ask me a question and then you mute me. No, we're talking about the levels of PEEP, are we? Yes. Yeah, okay. As far as non-invasive ventilation goes, CPAP certainly wouldn't start below 10. With the invasive ventilation, standard is 10 as well. We in the first wave were experimenting with 12 to 14, but we stopped doing that now. And I think some of the research actually backed that up a little bit. So occasionally we'll go up to 12. Most of our patients are on 10. We'll start weaning down from 10 once the oxygen levels start to creep down a little bit as well. But that's not really until they start hitting sort of 50, 40%. And it's the blood gases as well that are just amazing, really, aren't they? A year and a half ago, when you saw a blood gas that you see today, the whole team would have been rushing down to the ward and we'd have been sticking a tube in the patient. Now it's kind of, yeah, whatever, it's the same as all the others. And do they look comfortable is often the question that's asked now, isn't it? That seems to be the standard that you're measured by. Do they look comfortable? Yes, they look comfortable, but unfortunately, as somebody I think said earlier, they do desaturate really, really, really quickly, and then suddenly you're left with no choice. But unfortunately, we're at the stage now we have so many patients that sometimes we don't have the luxury of time. So yeah, PEEP of 10 is a standard, I would have thought.
Thank you, Danny. This age-old question: NG tubes and aspiration on NIV CPAP. If you have a patient with an NG tube on CPAP, now I do think CPAP is different from non-invasive ventilation, I have to say. So this is specifically around CPAP. Is there greater risk of aspiration?
Look, there's no evidence that suggests that. There's no study that says, yes, there is. I guess there is a theoretical risk. And certainly one of the discussions that's been kind of had within the critical care dietitians group is if people are worried about that risk, then placing a post-pyloric feeding tube rather than an NG tube is an option. And there are certainly centres where that fear is greater than others, or the perceived risk is greater than it is in other centres. And in that instance, I would suggest that rather than placing an NG tube in those patients, they should have a post-pyloric feeding tube placed. That is easier said than done, but that would be the next best option if, you know, there were concerns about that. But certainly there is no evidence to suggest that that is the case.
Thank you. And just a question while I'm on you. What would you recommend for a team or a service like yours? You work in a big inner city London teaching hospitals. If this was yourself 4 weeks ago, what would you be preparing your dietetic workforce for?
Okay, so the biggest issue that we've had, I would say, is the staffing issue. So for example, the Pan London guidance for critical care services for dietitians is suggesting a 1 dietitian to 20 bed ratio. I can tell you that that is not enough, simply because that doesn't account for sicknesses and absence, and it doesn't account for the amount of time that you have to spend on the unit, and it doesn't account for the fact that your redeployed staff will not be as quick at seeing patients as the more permanent members of staff. So I would say that you need to have a very good plan in place. In saying that, I thought we had a very good plan in place, and we don't. We haven't. I feel like we're still chasing our tail. So realistically for us, it's about planning, because if you don't have the staff, you can't deliver the service. So actually then it doesn't matter what's going on with the patients, because you can't deliver it. So it's really planning about staff. And as we've all said, a lot of the other services are still going. So actually getting those staff in is really, really, really difficult.
Thank you, Danny. I'm going to come to the physios next and ask them the same question. But before I do that, there was a couple of comments about lateral flow. So in my experience and other centres I've spoken to, the staff are being tested twice a week, lateral flow testing, and the lateral flows that come back positive, it very rarely, if ever, come back with a negative PCR. So they're pretty much spot on. So people are isolating if they have a positive lateral flow until they get a PCR, which is negative. And also if people have a contact with a positive patient or member of staff, their PPE has to be absolutely spot on. And if there's any breach of the PPE, they would need to isolate. The number of staff we're picking up that are asymptomatic on lateral flow is outstanding, probably because of this new variant. Again, I really encourage people to listen to the SICM webinar the other day, really good at talking about that and the transmission. And this is what we didn't have in the first wave. We didn't have testing. We didn't have staff needing to isolate. We didn't have staff contracting the virus at this rate. So that the workforce, like you said, Danny, is we're not just preparing for a normal workforce and surge, we're preparing for staffing sickness. And this is why, for the first time probably in your career, my career, we're asking staff to cancel leave en masse. We're saying we'll have such a focus on well-being, such a focus on people taking their annual leave, but we're saying we cannot cope unless you give 125%. And it's from the management side, that's the hardest thing, isn't it? So this is why, as in the words of Charlotte Summers, this is vaccines and research is the only way out, because this virus is going to continue. So again, trying to help prepare people who are listening who haven't been through this either in this country or beyond. From a physio point of view, Zoe, can I come to you first? What would you recommend for yourself 4 weeks ago?
I would have spent less time looking back at wave one about all the gazillions of staff that we had, and I would want to write a new story much sooner, because I spent far too long whining about not having any redeployed staff and needed to just grow a pair and think differently. Get everyone hood trained, because wearing hoods is lovely for the patients because they can see our faces. So that's been really good, and that's been quite time consuming. And I would say as well to anybody leading any team is get ready for non-clinical work, or people arriving who can't go onto the unit, have some jobs ready for people to do, because sometimes when you have people turning up and they're willing to help but can't go in, perhaps have things ready, like phoning the relatives for the patient profiles, the all about me information, filling in databases. Just get yourself ready with what you're going to ask people to do, depending on what their experience or whatever is.
Thank you. Pearlene.
I agree with what Zoe said. Basically, just make sure that you're prepared for the job roles, essentially. Ensure that you know what you want each person who's been, imagine if they have been redeployed to you, what role they are going to do. Planning for twilight shifts as well, ensuring that you have enough cover, and planning for sickness. That's probably one of the key things, to be honest. And also preparing your team to potentially stretch themselves to probably to new limits that they haven't really reached before, because we've dealt with the fact that we have staff sickness, but then we've gone from different ratios. For example, if we have 1 to 4 patients normally, that's then extended. You almost need to plan a baseline, a surge, and then a potential another surge if that happens, if you don't have the staff being redeployed to you as before.
Thank you. Maria, any top tips?
Yeah, so I think, the training is absolutely key. A lot of our non-respiratory nursing teams and wards who are now being asked to step up to covering all of the red patients that are coming in through the front door are feeling overwhelmed. We offered them training in wave 1, and we did a lot of training. We did a lot of online training, sort of 5-minute quick bites videos for them to be able to manage patients with respiratory disorders. But I think we got a little bit complacent when things quietened down and went back to our sort of ways of working. So now that we've had to re-prepare quite quickly again, certainly for the non-respiratory areas, I think in hindsight, I think we would have done better by sort of buddying them up with respiratory areas so that they were able to manage their patients, in a more effective way. And really just trying to support the staff through it. With the basic on the job training, online training, so that people felt that they were more ready for what we have now.
Thank you. Jonathan and Kate, I am going to come to you, but I want to come into Dorothy there, because was there a sense of not letting the guard down? I think that's the wrong terminology, but the breather was needed, wasn't it, after the first wave? It was like, let's pause, let's regather. Thinking now in this wave, what can we do to really look after ourselves, and some positive action points, and also for people who aren't quite at their peak, how can they prepare psychologically?
So no, I think that was right. I think it was good that there was a pause, and I think it was good that people did get that annual leave and that they got breaks, and I hope they're still going to be allowed to continue to have it when they can, because you can't have staff working at 125% for very long. And I think in terms of, I think what I'm glad I did do, there's things I wish I had done, but I think what I'm glad I did do is we really carried on with the staff support work ever since March right through till now. We had a range of different support groups for staff, reflective spaces for staff, places where people could, have one-to-one wellbeing sessions with us, get referred on for, we knew some staff were really traumatized, and we made sure that they were able to be picked up for some sort of much needed treatment. So I think we feel like we did the best we could in terms of staff support yeah, what people can do now is very much, it's just, the main things are the basics. It's just really basic. It's just, you know, you can't pour from an empty cup, and, you know, you've got to look after yourself before you can care for others, or while you care for others. So it is just all the things that are very easy to forget when you're, you know, you're very much under stress. Just eating well, exercising, talking to people, staying in touch with people, even if you can't see them, you know, thinking about coping strategies that usually work for you. There's not much point at this, in a time of crisis. It's not good to try and learn a whole new load of coping strategies. So if you do yoga, keep doing your yoga. If you know how to do breathing and relaxation exercises, keep using those. And, you know, if you feel that beyond self-care you need more, then use the apps that are on offer. Go to the NHS National Staff Helpline, and the Our NHS People website is a really, really good resource. So they have all sorts of things on there. Do have a look at it and get what support you can.
I love that. Do what you normally do. Don't try and learn anything else. That's such a simple but powerful point. Thank you so much. Right, Jonathan, coming to you, my friend, for your top tips. And please do put your website in the chat, because everyone keeps asking us.
Okay. My top tips. I think I'm very much with Dorothy on this. My mental health suffered quite badly in the first wave, and I ended up taking quite a lot of time off as a consequence of it. And one of the things that I learned from that is that your mental health comes first and foremost. And I think one of the things that you need to learn from that, and I'm going to quote you a prayer, I'm not a religious person at all, but I think it's so, so true. We're all resenting of people going out and about doing their things. We're all getting a little bit uptight about it, but it's just grant me the serenity to accept the things I cannot change, courage to change the things I can, and wisdom to know the difference. So chill out. You can change things. Go ahead and change them. If you can't, then we're going to have to live with it and keep moving forward, and just take care of yourself first and foremost, because I agree with Dorothy. If you don't do that first, you can't do the second bit.
Thank you so much. And who else to finish on after that incredible little summary, Jonathan? Thank you. Then the rehab legend herself, Kate. So, Kate, I am looking to you for a finale like no other. So this is your opportunity to tell us all how we're so amazing as a respiratory critical care community, as a real MDT, and how we will get through this. It's really tough, isn't it? It's really tough, but we will get through this together. So Kate, over to you to finish us off.
So I would say we absolutely will get through it, because we have no other option. We are literally all in the same boat. We're all paddling. It's going to be fine. We know it's going to be fine. The thing that I would say is that every day, even when it's really, really, really challenging, you see moments of the most beautiful sunshine, don't you? Sunshine in your colleagues, sometimes sunshine with your patients' faces when something really amazing happens. And the thing that I would say is, what is the reason we're all here tonight at 9 o'clock on a Tuesday? We're all here because we care about each other and we care about the patients. So I would say we need to be sharing our patient stories, sharing our patient successes. We made a patient successful, and you know I have the Balls to COVID campaign. So I'm basically getting, for January, it's an exclusive here, prepare yourselves, beach balls with Balls to COVID all over, and I'm going to send them to every intensive care in the whole of the UK, and any respiratory unit, whoever wants them, so people can start, you know, planning the summer and playing silly ball games with patients to support rehab, to support recovery, but also to see people smile, because in every moment of darkness there is always sunshine, there is always light, there is always beauty, and there is always our patients. And that's what we're here for. And I think tonight's been beautiful for everyone coming together to kind of, you know, prove that we're all in it together. But we will get through this. And like Charlotte said right at the beginning, look at what we have done in a year. You know, we are utterly amazing and utterly a team, and we need all of us. And I don't care whether you're a porter, a professor, a student, you know, we're all in it together, and we're all amazing. And I'm just so proud to be part of the NHS at the moment. So I want to say thank you to all of you for being just amazing, and just keep being yourselves, and we will get through this.
Well, thank you, Kate. I just have one more question. How big are your balls?
Massive. Huge balls.
Oh, I thought they were
got huge balls coming in January.
Oh, I thought they were going to be small balls. Okay, so we've got big
Rachel,
balls
you need a
coming
bigger
away.
hanky, I think.
Do you want small balls? Would you prefer small balls? I was thinking like, this is a good size. Come on, Zoe, help me with my ball. Is this a good size for physio?
The bigger the better, Kate. The bigger
That's
the
what
better.
I thought. Bigger the better. Always bigger the better.
Well, and on that note, I just want to thank you all for giving your time for free on top. Everyone's a clinician on this panel. I really appreciate it, and please take care of yourself.